Hello and welcome everyone. Thank you for joining today's session on your favorite channel, Cancer Reach. Cancer Reach is an initiative by our very own onco savior, Dr. Krishnamani, to spread awareness about cancer and help patients and caregivers access the right treatment at the right time. Microsatellite instability or MSI is one of the most important genetic signatures in cancer today. But what exactly is it and why does it matter? From guiding treatment decisions to identifying hereditary cancer risks, MSI is now changing how we understand and fight cancer. In this session, we are joined by our very own doctor who's going to break down what MSI is, how it is tested, and why MSI high cancers often respond differently to immunotherapy. Whether you're a student or just curious about cutting edge cancer research or a patient, this session is definitely for you. Without delaying further, I will now introduce our doctor to you today. Dr. Krishnamani has been associated with AOI hospitals here in Hyderabad since a decade now. He has extensive expertise in managing a wide range of cancers, including both solid and hematological malignancies. Throughout his career, he has been an integral part of various hospitals and organizations across India, earning recognition as one of the country's leading oncologists. In addition to his clinical practice, he has a deep interest in research and he has also participated in many clinical trials. His commitment to advancing the field of oncology is further demonstrated by his membership in American and European oncology societies. A very good afternoon to you, sir.
Good afternoon. Welcome all to Cancer Reach, which is an initiative to spread awareness on cancer.
So, what is the ideology or the main motive behind selecting this topic, like microsatellite instability in cancer?
See, we basically want to impart knowledge or want people to know certain things in cancer. That is our motto. And as you very rightly said, be it a layman, be it a patient, even if somebody is a fresh med student, this is an important topic because see, we talk a lot about research, right? We should do a lot of research and development, etc. This is one topic where research has come to bedside. That is, research is applied in clinical practice to help patients' lives. Many times, you may do experiments which are good in the lab, but they may not have clinical value. This is one such topic or one such area where your lab research has actually helped patients in the clinic. That is your microsatellite instability. That is the reason we chose this. This is something which has great application. This has changed the way we treat cancers today. And this has only been possible due to a lot of groundbreaking research. It is a new topic for patients maybe, but for oncologists, it is not so new. But as patients, as attenders, we don't discuss this. We talk about chemo side effects, or fancy things like immunotherapy. Why immunotherapy works in certain cancers, we don't know. That is because you are MSI high. Okay, so if you are MSI high, immunotherapy works. What is MSI? How do you test? Where do you test? That is why we wanted to cover all that today.
Okay, sir. So, what is this microsatellite instability and how does it actually occur?
So you have put a very beautiful picture, right? You have the DNA strand. You have these two strands. What happens is every day or every minute, the DNA strands at some place they may get damaged. I'm putting it very simply, not scientifically. So just to understand. So it is like they get damaged, they get repaired. They get damaged, they get repaired. It is an autonomous process. Imagine um, you are laying a road. It gets damaged, it gets repaired on its own. It gets damaged, it gets repaired on its own. How beautiful. That is, you don't need to do anything extra. It is, and what I'm talking is very, what do you say? It is not practical, but just imagine that the road inherently has a potential to get better or become normal. Same way, the DNA damages, it becomes better. The DNA damages, it becomes better. Because when you are constantly replicating, there are going to be problems or errors. Those errors by nature are rectified by certain enzymes, like, for example, DNA polymerases. at an area called replication fork. Okay. Now, this is the normal pathway. That means you are microsatellite stable. Microsatellite means small islands of these, what do you say? Microsatellite is a very, very small areas of the DNA, which when damaged are getting repaired. So if you are microsatellite stable, that means replication is occurring and healing is occurring. If you are microsatellite unstable, there are going to be replication errors and DNA damage. Now, this is utilized or in oncology. So, certain cancers are found to be microsatellite unstable or MSI high, we say, microsatellite instability high. The other cancers are microsatellite stable. So MSI high means your microsatellite unstable. Replication is not going as per plan. There are some errors which are occurring. This occurs in a few set of cancers. In a number, probably if you have 100 cancers, maybe 10 to 20 could be MSI high or 10 to 15 are MSI high. Generally in colon cancer or in endometrial or ovarian cancer. So those who are MSI high are potentially very good candidates for immunotherapy. And then next is how do you test and all that, which we will come to later.
So, sir, would you classify this condition as being inherited or a genetic trait?
So, see, there are multiple ways you have to look at it. So, mutations are of two types, germline and sporadic. Germline mutations are passed on from one generation to another. Sporadic mutations happen in that generation only. Then there is something called epigenetic alteration. That is, after the DNA work is all over, there is something called methylation which happens. There also you can have a damage. So now if you take the example, the classical example is colon cancer. So the MSI work or everything has actually, a bunch of work has been done in colon cancer. Colon cancer is a cancer which progresses in a stepwise fashion. It starts with adenoma, which is not cancer. Then it goes into carcinoma in situ, which is a precursor of cancer. And finally, it becomes carcinoma, which is called adenoma carcinoma sequence. Adenoma in situ and then carcinoma. At each step, there are some genes. In the initial step, there is a gene called APC, adenomatous polyposis coli, APC gene. So, initial step of colorectal cancer, APC gene involved. In the middle step, a gene called RAS is involved. In the final step, a gene called or mutation called P53 is involved. Now you're an MSI high. The initial step will be MSI. The middle step will be something called BRAF, B for Bombay. And the final step will be again your other mutations. So this APC mutation, which I said, is inherited. These patients are young patients. They have multiple family members. If you open their colon, they'll have cancer and multiple polyps, more than 100 polyps. Polyps are cauliflower growths. And if you test them, they are APC positive. This is an inherited condition. There is another inherited condition called attenuated polyposis. That is, they don't have hundreds of polyps, but they have few polyps. There are other inherited conditions which occur with other diseases, okay, like Peutz Jeghers syndrome, etc. So, to keep things simple, inherited means it runs in families. Many patients are affected. They can have hundreds of polyps in their colon. Commonest is FAP, familial adenomatous polyposis, where you have many polyps. There is another inherited condition without polyps that is called Lynch syndrome. Okay, that occurs in 10 to 15% patient. That Lynch syndrome is generally MSI high. That is hereditary non-polyposis colon cancer. So hereditary non-polyposis, no polyp, but colon cancer. And the biological footprint of that is being MSI high. Got it?
Yes, sir.
So what a student, for example, should understand is APC is the initial step, P53 is the last step. If you are MSI high, you should test for BRAF mutation. MSI is usually seen in 10 to 15% of colon cancers who also have probable Lynch syndrome. Or Lynch syndrome evaluation should be done.
Sir, when we talk about the epidemiology of MSI, can you walk us through which cancers it is most commonly associated with? And even in those cancers, what would be the average percentage of patients, like according to the Indian scenario?
So, see, you will only if you know MSI, you will test for MSI, then only you will know the actual incidence. But if you talk about colon cancers, the MSI high is between 15 to 20%. If you talk about gastric cancer, maybe MSI is again probably in 10 to 15% or 15 to 20%. It's also seen in a good amount of ovarian and endometrial cancer, probably slightly higher in endometrial cancer.
And sir, approximately like in your day-to-day activities, when you're seeing patients in the OPD, approximately like say out of 10, how many patients would actually be MSI high?
1 to 2.
1 to 2. Okay, sir. So what is the clinical significance of it? Like before we get into the diagnosis and the treatment part of it, how do you clinically diagnose it, or how do you see for clinical symptoms of MSI high in patients?
So now for colon, see, MSI is a routine part of evaluation now for colon cancer, for stomach cancer, for any cancer for that matter, simply because any solid tumor with MSI high is a candidate for immunotherapy. If you follow that rule, every patient should have an MSI status. Commonly, we do it in colon, endometrial, and we do it in stomach. Okay, ovarian also, but commonly colon, endometrium, and stomach.
And so like is should like all patients who come to the clinic, like any cancer, like say like you said ovarian or stomach cancer or colon cancer, they all will be tested for MSI high status, for the MSI status in general, all patients or only specific group of patients?
Now, colon, there are two groups we test. One is stage 2, that is node negative. So, stage 1, you don't need any chemo after surgery. Stage 3, you definitely need chemo. Stage 2, you may need, you may not need. Injectable chemo may be given or nothing may be given. Only tablets may be given. That is decided based on MSI. So we do MSI in stage 2 colon cancers. They are node negative colon cancers. Based on MSI and certain other factors, which is called risk factors, you decide whether these patients need oral chemo or oral plus IV or nothing. So there we do MSI, number one. Number two, in stage 4 colon we do. Because if you are MSI high stage 4 colon cancer, you don't need chemotherapy, you will be put on immunotherapy.
Okay. So how do you diagnose this? Are there specific tests for diagnosing the MSI status in cancer patients?
So you can do it by two ways, one by IHC, one by mutation testing, molecular profiling. First, you will do an IHC. If for MSI, there are, mismatch repair proteins, we call that. There are four, MLH1, PMS2, PMS6, MSH2. There are four proteins. Okay. So first you will do an IHC. If all the four proteins are intact, that means your MSI stable. If any one is absent, for example, MLH1 is absent, then what you should do is you have done IHC, right? Now you do molecular testing, and MLH1 means please do BRAF testing. Okay, because if you are BRAF positive, it negates the good thing of your MSI high. Got it? And this is because of epigenetic change, we say. So to keep things very simple, not to confuse, you will do IHC on the tumor. Every tumor IHC is done. If all are intact, you are MSI stable. MSS we call that. If you lose any protein, you are MSI high. Then you will do molecular testing on that to see which among the four are gone. If you have MLH or including PMS2, then you will do BRAF testing. That is the way you finish your algorithm. So you
And
will do a combination of IHC and molecular methods.
okay. And so once you have the results of the diagnostic test, is that the right time to check for the prognosis of the disease based on only the MSI status of the patient?
So I'll give you an example. I just told you MSI high colorectal cancers, we give immunotherapy today. The patients who receive immunotherapy, when they are compared to chemotherapy, they live 1 year longer almost. So what does it mean? The prognosis is good. But if you are BRAF positive, it reduces your prognosis a little bit. It's a learning process. There's a lot of work going on here. But MSI high, poor responders to chemo, good responders to immunotherapy, BRAF positive may probably negate some of those results.
Okay, sir. Sir, when deciding the treatment, how do you place the MSI status for a particular patient for any of the listed cancers that we just spoke about? How does it influence the treatment that you're going to give to that patient?
Earlier for chemo, for colon cancer, even now for colon cancer, if MSI was not done, we just give chemo for everybody. For endometrial cancer, we used to give paclitaxel carboplatin for everybody. Now, if you're MSI high, you get immunotherapy. What immunotherapy? You receive ideally dual immunotherapy, nivolumab plus ipilimumab. Nivolumab is a PD-1 blocker. Ipilimumab is something called CTLA4 inhibitor. So you use two immunotherapies with different mechanism of action, which has best results. If you cannot use two immunotherapies, we either use a drug called pembrolizumab or dostarlimab. This immunotherapy in MSI high patients increases their survival, increases something called progression-free survival. That is the time, the amount they live without progression, and increases the response rate also. So in many ways, it is very helpful. And the survival goes beyond a year.
When we talk about the MSI status, should we also focus on the cost factor for Indian patients?
Correct. So obviously, on these patients' blocks only, you are doing the MSI. And if they are MSI, you are classifying. So today, at any given time, if you are MSI high or humor mutation burden high, on your NGS testing, we say, they are candidates for immunotherapy.
Okay, sir. And sir, the MSI testing is in itself, is it costly for a patient or is it on an average cost scale?
On an IHC, you can probably do it for less than 10,000. And on NGS platform, you can do it for probably less than 20,000.
Okay, sir. Are there any specific type of approved, like FDA approved treatment for MSI high cancers?
Nivolumab, ipilimumab, dostarlimab, pembrolizumab, all are immunotherapy combinations, all are FDA approved. Nivo, Ipi, and Pembro are available in India, and we use it very, very commonly. And they are not chemotherapy. They don't have side effects like chemotherapy. They are IV injections. They don't have complications like hair fall and fall in WBC count and all that. But yes, these medicines can sometimes cause thyroid problems, skin dermatitis, colitis. They can cause pancreatitis, liver enzyme issues, etc. But they're very, very safe.
Okay, sir. So now we will move on to bursting a few myths about MSI. So the first one is that many people hear genetic and assume that it's inherited. So is it always inherited or is it always hereditary?
No, for that, as I told you, you have to do those stepwise analysis. If you look at the classical colorectal cancer, 85% are sporadic. They are not inherited. Only 10 to 15% are inherited.
A high MSI score means that the cancer is more aggressive in nature.
Not really. High MSI means the cancer is more responsive to immunotherapy.
Okay. And the last one is that if someone has MSI high tumor, does that mean that the family members are also at risk?
So yes, if MSI high tumor means, then what you are going to do is you have to test for Lynch syndrome. You have to do genetic screening. If they have if they are positive on the genetic screening, they have a risk for Lynch syndrome. So they have to be screened 5 to earlier to the first fit.
Okay, sir. So, sir, we would be ending this session, but before we do that, would you want to give a short summary for today's session?
So for our patients, what I would say is, see, MSI is a new concept. MSI testing is important in commonly colorectal endometrial cancers. MSI high tumors respond heavily to very well to immunotherapy. So this is a significant move for us from the chemotherapy era. And it can be done by two methods. One is IHC and one is molecular. And these tests are available at most places and they are not expensive. So every patient should get the benefit of MSI testing to see if he or she is eligible for immunotherapy.
And so, before we officially close the session, can you tell us about your second opinion campaign that you're doing for patients?
So, as you know, as we all know, we are doing so Cancer Reach is basically cancer information reaching each and everyone. That's our motto. So, we want the cancer information to reach people. And if people want to reach out to us, we have a WhatsApp number. They can WhatsApp us their reports. They will get in the recommendation, what is best from our side without seeing the patient, free of cost. So this is a free second opinion campaign. You have a WhatsApp number. You can WhatsApp that number and put your reports, and we would do our best to give you a opinion as much as possible. That is number one. Number two, I would also like to take this initiative because tomorrow is World No Tobacco Day. And at Cancer Reach, we are striving that people should be away from tobacco products, etc. The WHO theme this year is unmasking the what is it? It is unmasking the mm, appeal. So now tobacco products are being told or being what do you say? It is basically being sold to the very young people in the form of candies, in the form of confectionaries, with a lot of coloring, making it more attractive with sweeteners like chocolates, so that children get attracted to it and all that. So that is why the WHO this year has put the theme unmasking the appeal. That is, industries are resorting to this kind of tactic so that children get addicted and they smoke or take tobacco for a longer period of time. So we at Cancer Reach appeal no tobacco day, not only on 31st May, all through the year, all through your life. No cigarettes, no e-cigarettes, no pan masala gutka. Prevent more than 14 types of cancer. Commonly head and neck cancers, esophagus, stomach, prostate, bladder cancers. So say no to tobacco. If you stop tobacco, almost 40% of cancer burden comes down. So be tobacco free, be cancer free.
Thank you for sharing this information with us and also for sharing so many insights on today's topic, which was a little complex to understand, but you have made it extremely easy and in a layman language so that we all can gain insights from it. Thank you for your time, sir, and we hope to see you again on next Friday.
Thank you so much.
Thank you, sir.
Bye.